I think our collective failure, myself included, to question our assumptions results in new forms of iatrogenic multimorbidity for our profession. Let me cite 5 that come immediately to mind. Morbidity 1 is good rigorous science means manipulating only one variable. But if we state a single variable science, it restricts the scientific studies that can be done. And single variable science results in single variable medicine. So a great example that Dr. Bill Manahan identified recently was Professor of Neurology Dale Bredesen at UCLA Medical School has a comprehensive approach to early minimal cognitive change. He's published case reports of 100 improvements. He wants to do a randomized controlled trial. Won't pass the IRB because there's not a single variable. It's a multivariable approach. And they say, that's not good science. We only address good science. Now, think about our 72-year-old gentleman with 9 easily reversible causes. Think about sitting on 9 tacks. And let's take 1 or 2 of those tacks. Are you going to notice a big difference? I think you have to take all 9 tacks. Second point, good rigorous science is only found in randomized controlled trials. Wait a second. What happens when we cannot randomize? If anything we know from genomics now, we can't randomize. Or it's profoundly more difficult, and you can't do it on like men versus women, black versus white, old versus young, pure superficial variables, meaningless these days. And how do we account for referral biases in clinical trials? You're not going to find the elderly with multimorbidity diseases with maybe a short time span looking at doing a clinical trial. So automatically you're looking at young people with single variable disease. And so that implies that somehow what we consider evidence-based medicine isn't necessarily the reference population that we might be seeing. Point 3, we're never going to have rigorous randomized controlled trials on low-cost, low-toxicity interventions. Something that costs $5 a month is never going to generate a $10 million, $20 million, or $30 million trial. It's never going to happen. Fourth point, the absence of randomized controlled trials for low-cost, low-toxicity interventions or for multidimensional interventions means that these will never be part of national guidelines or standards for medical care. The rules of science are the only thing that's allowed into national guidelines are randomized controlled trial data. Now, this is pretty wild. I asked Barbara Yawn recently, she chaired the sickle cell national guidelines. I said, tell me about vitamin D. She goes, what about vitamin D? I said, well, Johns Hopkins, University of Pennsylvania, University of Chicago report upwards of 100% of their children with sickle cell have severe vitamin D deficiency. Did you make a recommendation to test vitamin D? She said, no. I said, what do you mean? She said, there's no randomized controlled trials that would be meaningful. Oh. The entire NIH budget for sickle cell is like $2 million a year. Is that going to happen? And in a community that's already dealt with Tuskegee and the like, are people going to say, what, you're going to find my child deficient and randomize them to placebo or something else? I don't think so. So, morbidity 5. There's no evidence-based medicine or no community standard of care for persons at the left tail. Doesn't exist. Everything there is experimental. And by the insurance rules, that means nothing needs to be covered. Any medical intervention, even if it's beneficial, any medical testing, even if it demonstrates markedly abnormal things that can be adjusted, addressed, no insurance coverage for that. So we're really in a bind. And what's this bind? Well, think about what's ahead of us. An aging population, the greatest challenge is going to be polymorbidity. And if healthcare innovation is restricting to standardizing processes, then like with Henry Ford's assembly line, we can have any color as long as it's black. So in the future, we're going to increasingly work where there are no guidelines. We will need, what we need then? On-the-ground creativity and flexibility, not auto-assembly lines. So we're going to wrestle with things like computing risk, total burden, uncertain net benefit. And this is exactly where Dr. Sweet was doing her best work. It's kind of, you know what? At Laguna Honda Hospital, where she practiced, the Alms Hospital, it's like they weren't under pressure until the efficiency experts came in and forced upon them changes that turned out to be adverse for patient well-being. So what I see is a system of fast medicine, of convenience medicine, where the review of systems has replaced the history of present illness, where checklists replace relationships, where face-to-face time has been replaced with screen time, and unassigned free time, what's been filled to the max for efficiency. And this all appears to be grounded on this, on what I call bell curve thinking. That is, worship of evidence-based, single morbidity, single variable interventions for populations rather than individuals. And no one talks about this inherent contradiction that the sum of multiple randomized, of multiple single variable interventions does not constitute an evidence-based intervention. So, I want to end with, is there a way out? And I want to suggest that we focus on the 5 lessons here, because none of them are new. They're rediscoveries or reminders of what our predecessors probably knew really well. Relationships count. Time counts. New questions count. And these count in ways that can never be counted. So, lesson 1. The best medicine may not be medicine at all. In fact, not prescribing or prescribing something different may be most important. Lesson 2, interview for the meanings, belief, and interpretations. Understand what's most important to this person. Lesson 3, focus on both curing and healing, the technical fix and the adaptive response. Lesson 4, take time to ponder and ask new questions. Lesson 5, be aware of the tyranny of bell curve thinking and the hidden value judgments that can be disguised as science. So, I believe we live in an era of dehumanization. We might call that burnout. But it's true for both ourselves as well as for our patients. I'm hopeful. So I want to conclude today with a positive note. What Victoria Sweet said, medicine is personal, face to face. And when it's personal, it works. And so my fervent hope is that you will find some hope in these lessons, and that together we can work to make it a better world for ourselves and our patients. Thank you very much. Thank you.